This is cognitive processing therapy for PTSD, applying cognitive theory to trauma, workshop I did at the Regis University. My name is Mike Morrow, and we'll get into that here. Okay. Um, I like QR codes. I've been putting them on some of these workshops, so feel free to pick up this slide deck through the QR code on the left and connect with me on LinkedIn in the QR code on the right. Important note, this is a post-traumatic stress disorder conversation, so we will have discussions of rape, combat, and other adverse events. So things that may be disturbing for some folks to talk about and listen to. And just as a reminder, this is a uh, workshop that was built for clinicians in training. So if you're uncomfortable with this content, I would suggest being cautious as you move through it. Introduction. So, who am I? I have a BS and an MS in psychology. I'm a licensed addictions counselor. I'm a licensed professional counselor. I'm affiliate faculty at Regis University and a clinical therapist at Lyra Health. I'm also a doctoral student at Regis University. I worked most of my career in substance use and community behavioral health. Um, Authored a chapter on trauma treatments for PTSD with my mentor, Dr. Christina Hesija, for the Sage Encyclopedia, and a variety of other kind of small credential items to build credibility. Overview. So, what we're going to be talking about today is the theoretical evolution of PTSD. We'll talk assessment and timeline, and then we'll talk a little bit about CPT versus CPTA, which is CPT with accounts, so cognitive processing therapy with the accounts. We'll also talk about cognitive processing therapy techniques and a little bit about session summaries, so what you might expect in any particular session. So, we're looking at PTSD criterion A. So, criterion A, this is within the DSM. When you're looking at the different criteria for any particular disorder, we're looking at PTSD criteria. That first criterion A, exposure to actual or threatened death, serious injury, or sexual violence in one or more of the following ways: directly experiencing, witnessing in person, learning it happened to a close friend or family member, experiencing repeated exposure to aversive details, such as first responders, collecting remains, law enforcement, things like that. So this is the initial criteria that's required for somebody to be able to be diagnosed with PTSD based on the DSM criteria. Um, the next here is criterion B through H. So, kind of a summary of some of the other symptoms. So, intrusive symptoms tend to be in that criterion B. Avoidance system symptoms, they're in that criteria C. A drop in mood or a difference in mood is in that criteria D. Arousal symptoms will be in that criteria A. Criteria F has more than a month of symptoms, meaning there needs to be a time of these symptoms to be occurring for at least more than 30 days. And G causes significant distress, and then also not better explained by substances. That's an often, as a side note, that's an often criteria in most DSM disorders, is that if it's explained by some substance, it disqualifies this disorder. Evolution of PTSD theory. So we're going to go into Mauer's two-factor theory. I don't know if I'm pronouncing his name right, to be honest with you, but it's the two-factor theory, where we look at classical conditioning. A fear can be learned and paired with an unconditioned stimulus. So this is that Ivan Pavlov's dog conditioning, where we ring a bell. And I love this example as a reduction example. It's not exactly what happened in the experiment, but this is how I like to explain it. We ring a bell and we feed the dog a steak. Ring a bell and we feed a dog a steak. Um, we're measuring the saliva over time. Sometimes if we ring that bell and don't feed a steak, then we still get saliva. And so that's part of that classical conditioning. Operant conditioning is where we're looking at reinforcements, positive reinforcement, negative reinforcement, the different things that change behavior, reinforcements and punishments. And so when we're looking at classical conditioning and operant conditioning, we got to look at the combination of the two when we're thinking about the two-factor theory. So avoiding the fear stimulus reinforces the avoidance behavior by immediately providing relief from that fear. Let me explain this or break this down a little bit more. I have some experience that allows me to be conditioned. In other videos, I've talked about some other stimulus, so I'm going to use something new. I get ran over by a red car. I now associate red cars with anxiety, so that red car becomes the the bell, and my anxiety is my saliva in the Pavlov experiment. I see a red car and I get a spike in anxiety. When I leave when I get away from that red car, when I avoid it, when I close my eyes, when I do something to avoid that experience, it lowers my anxiety back down. This reinforces, this is a part of the operant conditioning. It reinforces the avoidant behavior, encourages more avoidant behavior. So classical conditioning is the pairing of something in the environment with my anxiety. Operant conditioning is the avoiding it and being reinforced for that avoidance because it lowers my anxiety as I avoid it. So another example is if I'm listening to a song during a car accident, perhaps I'm driving around or walking around and the song is being played. I get spike in anxiety when that happens. And then when I turn off the song, the relief is experienced. And then that further reinforces the avoidance. So as soon as I kill that song, as soon as I cut it off, all of a sudden I'm feeling, oh, okay, I'm away from it. And then that encourages me next time to also turn off the song, to continue avoiding cues, and teaching me that not only is the anxiety correct in its evaluation of the danger, but that it is something to avoid. Evolution of PTSD theory, bioinformational theory. So this is Lang's bioinformational theory, which is really interesting around emotional imagery. So information held in our attention, especially emotional imagery such as threat, can impact our behavior. So when people imagine a task, they tend to move their limbs, right? You can think of people who like to talk with their hands. So when people are asked about their experience with the Eiffel Tower, for instance, they may look up to describe the experience. And so what this means is that our attention, so we don't have to have actual physical things in the environment that impact us for an emotional reaction to occur. What this bioinformational theory gives us is it lets us know that in our imagination we can create an emotional experience. And I would imagine you could find something similar, like if you've ever read a novel that was really touching, or if you've ever listened to an audiobook or watched a movie, it's all imaginary. And I think this is especially true with a good book. It's all imaginary. It's simply words on a piece of paper, and yet it can evoke an emotion in us. This is deeply important to PTSD theory as we start to think about PTSD as a relationship to a fear of memories. So if we have a fear of memories, then we can start to think about, okay, when those memories are in our attention, we would experience and suggest that that emotional reaction is tied directly to the recall of that memory, um, as predicted by bioinformational theory. Now, we start to see all of these start to get combined into emotional processing theory. Emotional processing theory is one where we're looking at fear structures being created in some event that is adverse, and then that those fear structures, meaning like scripts for how to behave during a traumatic event or during a scary event or a fear activating event. So we have these scripts. Okay, how do I get out of here? What do I do? What do I need? So emotional processing theory suggests that if we want to change those scripts, we need to be we need to be engaged in the stimulus, like whatever causes the fear. So going back to my red car example, if I have a phobia of red cars, I need to be next to a red car and disconfirm my fears and my danger and my threats and danger. Does so what that means is I need to have some cue, spikes my fear, spikes my emotion, and then by process of just being present with that stimulus, my automated systems and my schema should start to correct itself by learning disconfirming information about the experience with this. stimulus, realizing that it is objectively safe and that it is not dangerous to be simply near a red car. So the evolution of PTSD, cognitive therapy. So it's important to talk about cognitive therapy as it is the application of much of the empirical science of therapy. So Beck's cognitive therapy, 60 years ago, uh, 60 plus now, Beck comes up with this concept that people hold erroneous beliefs about themselves and the world, which leads to disturbances of mood. Originally, he starts to use this with folks who have depression, realizing that some beliefs and attitudes tend to be what in therapy we can often call them, or cognitive behavioral therapy specifically, we would call like a maintenance mechanism, the mechanism that keeps the disorder in place. And so what he realizes is that if we change these beliefs, and this results in changing the person's mood. So we're encouraging the person to start to change their attitudes and beliefs about the world or about themselves, and this then can have an impact on their mood, which later impacts their functioning and their general behavior. Often this is done through Socratic questioning. So we're engaging in that classic style of prove to me what you know through me asking questions in that classic Socrates style. So I wanna slow down here and do a quick kind of categorization of all these things. The first couple of items we've talked about, Mauer's two-factor theory. We've also talked about the uh, bioinformational theory, and then we also talked about emotional processing theory. In all of these theories, they're kind of abstract and describe human behavior generally. Now we're getting into an applied concept with Beck's cognitive therapy. How do we exhibit change in the therapy room? This is where Mahoney's constructivist concept comes back. So now we need to kind of go back into sort of a theory concept. So humans are active participants in their world and they develop their own understanding of things. So this idea is that as we move around the world, we need to organize, make sense of, make patterns in the world. We create habits that become automated over time, and so we can engage in the world sort of second nature. And so we're looking at we're looking at this idea that, okay, I'm in the world, I'm constructing meaning about it. I'm constructing meaning about it. And then Beck is also saying, hey, maybe those meanings, if they have some sort of errors in them or inaccuracies in them, it can result in depressive feelings or feelings of um, malcontent. And so, how can we help someone engage in a better and healthier life? And part of that may be touching on some of their attitudes and beliefs as they've constructed them. And then what becomes really interesting is we start to touch on these earlier theories that we talked about, like the two-factor theory and the emotional processing theory, in the lens of a traumatic event. So, what does your worldview look like if it's been constructed under this traumatic event lens? Do you have a different construction than other people who would not have had these sorts of traumatic events? This is where schema comes in. So there's a lot of concepts all dancing around here at once, but schema is also very important. Cognitive therapists are starting to describe schema processes in traumatic situations. So early versions propose that one of two things occurred: change in the information in the traumatic event fit the schema, or change to the schema fit the traumatic event. But first, let me talk about a little bit about what a schema is. So a schema is a an underlying attitude that or a core belief or a belief that you have about the world, right? So we have to have schema in order to operate in the world without having to make deep processing or intense time consuming decisions at any given moment. Uh, for instance, I would imagine most of us have a schema for driving a car. It would be really time consuming if we had to relearn and make a decision on every aspect of the internal mechanisms of our car. So we have the blinker, We have our shifter. We can move between the two pretty seamlessly. We know where the radio knobs are. We don't have to actively think about it like it was the very first day you drove. The very first day you drove, I would imagine there was a lot more learning involved and a lot more of habit forming you had to create. Well, once you have those habits, once you've learned something, what is that thing? What do we call that abstract idea that you've learned something? We call it a schema. The schema is your schematic or your idea of how any particular part of the world works. So, going into constructivism, we're looking at, okay, we're making sense of the world and we're starting to design our internal patterns for how the world works. And what we would call that technology that you've created, that software that you've created up there, we would call it a schema. You've developed a schema. This is how the world works. This is how I engage in the world. And so, again, kind of foreshadowing a bit, what happens when your schema and when your construction of your attitudes, beliefs about the world were formed in a traumatic situation. So this is where cognitive processing therapy takes all of the things we've talked about so far and puts them together into one applicable treatment. So I'm not going to pretend I can pronounce their names. I've only seen it in print, but Reesick and Schnick proposed cognitive processing therapy. So it incorporates aspects of each of the earlier theories into a unifying treatment for PTSD, suggesting that PTSD is a disorder of avoidance due to behavioral reinforcement of evading emotional content. So that's really important. Comes back to that Maurer's two-factor theory, where I need to avoid emotional content because it spikes my anxiety, and I've learned that avoiding it reduces my anxiety. It also looks at that the fact that people make meaning of their world and sometimes use cognitive distortions and faulty construction to do so after a traumatic event. We've talked about that a couple of times so far, but this is where cognitive processing therapy really focuses: is how how have you made meaning of the world, and is that an effective or helpful meaning for you personally, or is it making your world smaller and your life harder? And lastly, when a trauma event does not match existing schema, your existing attitudes, your existing core beliefs, some folks will change the facts of the event to keep the schema, or sometimes they will change the schema so radically in order to accommodate the facts that it can create its problems of its own. And we'll talk a little bit about that soon. So PTSD theory cognitive model. So this is written by Ehlers and Clark. It's a later version of PTSD theory, which encompasses all that we've learned in all of these other theories, plus a little bit more. It's a very robust concept. So I put a QR code here. So if you want to dive deep into the literature, it's available. But I think Ehlers and Clark is a really great seminal article for anybody who wants to dive deep into cognitive behavioral therapy and PTSD and how they overlap. So, CPT, information processing. So, a really important concept is that the mechanism of PTSD, one of the major mechanisms of PTSD is either this concept of assimilation or over accommodation. So, let me talk a little bit about these three items before we worry too much about uh, where anyone fits in one particular piece. So the idea is that in information gathering, you have three choices. You can assimilate the information. So the facts of the event must change in order to fit a core belief or schema I have. I already have a worldview. If I don't plan on changing it, and I find data that does not fit my worldview, then I need to change that data in order to help fit my worldview. So that would be a simulation. Another one is accommodation. So we find data that doesn't work with our worldview. So then we slightly change our worldview. We add nuance into our worldview in order to accommodate this new information without drastically changing too much of our behavior or worldviews or attitudes. And then there's over accommodation. And this is where we overgeneralize the change in the schema. So some event occurs that has data in it that challenges my core belief, then I'm radically, drastically changing my core belief in order to fit for this new data. But it's so drastic and so radical that it tends not to have nuance of its own. So looking at these three items, a simulation, accommodation, and over accommodation, what would be suggested is that folks who end up developing PTSD likely fall into either the assimilation category or the over accommodation category. So one experience that I often like to talk about as kind of a straightforward experience is if you were mugged. Let's say you were mugged. A simulation would suggest that, okay, I need to keep this world belief that the world is fair. Good things happen to good people, bad things happen to bad people. So therefore, if I'm assimilating the fact that I got mugged, this is a bad thing that happened to me. If I still believe I either have to believe I'm a good person, but I did something bad, or that I'm a bad person generally, right? So changing the facts of the traumatic event to fit a pre-existing schema would mean then I would look at this event and um, I would look at this event and I would say, it's my own fault. I should have never been wearing flashy clothes in this space. I should have never shown up flaunting what I had. I should have known better than to be in a space like that. This is my own fault. Accommodation might have some more nuance to it, not change the data too much, and just say, sometimes things like this happen to people. It can be somewhat random, but mostly when people do good things happen. And then over accommodation would be flipping the script entirely. It would be saying something to the effect of, there are no good people in the world. It's a dog eat dog world, and the whole thing is dangerous. And so, why it matters how we assimilate this information is because, or accommodate the information, or over accommodate, is because if we are taking the information and we are changing it so wildly that it becomes inaccurate, we tend to either shrink our life or live in resentment towards ourselves or regret, right? Because I would be saying, it's my own fault. I'm a bad person. How could I do this to myself? Um, this also has implications that maybe I'm just not smart enough, not capable enough, I have no self-efficacy. The over accommodation could lead us into behaviors and attitudes that suggest like it's a dog eat dog world. I got to get them first, leading to, what they call antisocial behaviors in the psychology world, which is kind of like those rights violating behaviors of others. So if you're in a dog eat dog world, it's kind of you start to get into that how sociopaths think a little bit, right? And you start to do things that are a little um, bully-esque, and let's say it's not that in the overaccommodation. Let's just say it's a dangerous world generally, and I don't plan on participating in the doggy dog world. Well, then maybe I'm shrinking my life down to almost nothing, to where I'm not participating anymore, and I'm retreating away in a very unhelpful and unhealthy way. So CPT accommodation. Since accommodation is a goal, we have to work on thoughts that are either over accommodating or assimilating, as we talked about a little bit just now. So what does it consist of? What will CPT consist of? So this is straight out of the manual. Copy and paste straight out of the manual. Cognitive processing therapy consists of 6 to 18 individual one-on-one therapy sessions. The average is 12. Each session lasts 50 to 60 minutes. In these sessions, you will learn about the symptoms of PTSD and the reasons why some people develop it. You and your therapist will identify and explore how your trauma or traumas have changed your thoughts and beliefs, and how some of these ways of thinking may keep you stuck in your symptoms. CPT does not involve repeatedly reviewing the details of your traumas. However, you will be asked to examine your experiences in order to understand how they've affected your thoughts, feelings, and behaviors. This is a really important concept, this stuck, and we're going to get a little bit more into it. Stuck points is in the broader literature, it would be often referred to as like mechanisms of maintenance or maintenance mechanisms, things that keep the disorder around. These stuck points would be attitudes and beliefs that keep us in this cycle of avoidance and really maintaining the PTSD symptoms. So here's some assessments that a clinician can give to a client to help them gather some information on PTSD. So this is a PCL-5. I believe this one I pulled off of the Veterans Affairs website, which they make so many resources free. So great organization for resources, especially if you want to help work with clients from an evidence-based perspective. So the PCL-5 is there. And then this is the life events checklist. It's literally a checklist of items that have adversive events in them, including high-end traumatic events that fit a criterion A definition. So you can use that as a way to assess and start to build out the timeline of PTSD. Speaking of timelines, one of the things that the authors of cognitive processing therapy would suggest or offer is to be able to build out a timeline. So, especially for folks who have a lot of criterion A events throughout their life, it might be helpful to build out a timeline that allows you to organize where some of the events occurred, at what ages, and which ones were impactful. This can also help with finding what they call an index trauma. So, an index trauma, as we understand it, is the trauma that we'll be working on through treatment. Often, often defined as is like one of the most impactful traumas in their life, one of the most impactful experiences. So, so this can be helpful in narrowing that down. Impact statements. So, impact statements are real in-depth, long written form accounts, well, not accounts, but long written forms of why the traumatic event occurred. So not the factual events, not yet. It is instead it's focusing on what happened, why, what do I think caused it. This helps us to illuminate some of the stuck points that might be occurring. So as they go through and write why did this happen? Why did that happen? Why did this happen? We can start to hear themes of accommodated thoughts or over accommodated thoughts, or assimilated thoughts. And so we want to find these stuck points, and this is a great way to do it because that gives them a lot of fodder to write out the content that we really need access to. So what are the stuck points? What are stuck points? What do they sound like when they show up? So I must have been bad for this to have occurred. I must have done something for them to think it was okay. I will be abused at any time again. All people are more powerful than me. Of course, this is all straight out of the cognitive processing therapy manual. Um, I am ugly and stupid. The world is unsafe. Home is the only safe place. I can't work. If I spend too much time out in the world, an event like my past event will take place again. I'm dirty. Other people view me as dirty. Others can't be trusted when they make promises. And so, what's really important about all these stuck points is you may be sitting there looking at these and going, like, well, of course somebody feels like that after some sort of traumatic event. But I think what's important to really point out and identify is the lack of nuance in any of these thought patterns. So it starts to become so overgeneralized that there means there is zero safe people in the world. And probability wise, I just don't think that that's true, that there's zero safe people out of 7 billion people on the planet. It just doesn't seem likely. So there is a lot of a lack of nuance in these sorts of comments and content, and which then would result in avoidance behaviors or more maladaptive coping that just drives and doesn't help someone in their recovery process. Here's another long list of stuck points from the handouts that the client would receive during cognitive processing therapy. Socratic dialogue. So one of the ways we work in cognitive processing therapy is to use Socratic dialogue. So similar to other cognitive therapies, and this is why we brought up the Beckian version of cognitive therapy early on, because he understood early that when working with people with depression, you have to start focusing on how do you start changing their thoughts and beliefs. And he used Socratic questioning, Socratic dialogue. Well, here in cognitive processing therapy, they're using that same technique, but they're more specifically putting it towards PTSD related thoughts and trauma events. So questions. Clarifying questions could be something like, you were saying that it was your fault for this, but then you told me about how you were not at fault because of this. Help me make sense of all of these things. And so you're really diving into the details because what it allows is for nuance building in the person's biography of sorts. So they're getting into the traumatic event or the content around the traumatic event, and we're breaking down some of these thoughts of dissonance that occur where it's my fault, yet I was 4 years old, and they don't believe 4 year olds are at fault normally. So why is it that they're held responsible or held to account? And this is where we can start to engage in building out some of the more nuance in the thinking, which that complexity really adds to reducing the emotional turmoil because it encourages a more sophisticated view of the event, which then encourages the ability to kind of re-engage in life. I mean, it's just it's education of some sorts. It's like it's adding into critical thinking about the event. Underlying assumptions. So we want to really break down some of these underlying assumptions. If it was my fault that I was mugged, then that means nobody's allowed to walk freely in the world. And so some of these underlying assumptions might also have implied downline behavior change. So we want to start talking about these underlying assumptions. So, do you believe nobody has the right to walk around in the world and start working through their own rationale on it? We want to evaluate objective evidence. Uh, some objective evidence is really important because what I've experienced, this is my own personal experience with treating folks who have PTSD, is that sometimes the temporal aspects or the time of when things occurred isn't always clear until the narrative is redone. And not saying that you would be necessarily doing a narrative in here, but as you're evaluating objective evidence, it might start to make sense of why they made the decisions they made at the time because of the cues they had in the environment. So, what would that mean? So, let's say I was going to walk down this street, this dark alleyway that I was going to be mugged in. I might suffer from what they call a knew it all along effect. So after I was mugged, I knew, of course, that was a dangerous alleyway. Why wouldn't it have been a dangerous alleyway? I have no reason to believe that was a safe alleyway. Once I got mugged, right? That becomes obvious. Well, there must have been some rationality that before there must have been some rational argument before you went in the alleyway and before you got mugged that made sense of walking down that alleyway. And so often the devil's in the details in that one. So what was it that cued them down that alleyway? And does that alleviate them of some of these ideas that they were dumb or reckless? Because it may be that literally their smartphone directions told them to go there. They had no other alternative route or something to that effect. Um, which then kind of suggests that like they were just operating normally and they had no real evidence to suggest that this was dangerous until after it already occurred. So while this is kind of a reductionist, a reduced example, I still think it's a really important concept because people can get really caught up in thinking they should have known something as if their IQ is somehow lower after the or before the traumatic event, and now they can really see the world clearly. When the fact is they were probably just doing the best decision making with what they had at the time. And then we also want to explore some deeper beliefs. So some of these beliefs we want to challenge, especially if it's, I am like the I am dirty stuck point is a really important one to challenge. The I am dirty. What does that mean? How does that translate more generally to the rest of people? Why would you give other people more compassion than you give yourself? And using Socratic dialogue to kind of break these down. The way I'm describing it here can feel very clinical or intellectual, but in the actual therapy room, you're going to want to approach this with a high level of empathy. You'll want to pace it at an appropriate measure in line with the person you're working with, and you sincerely need the trust built up with them and the relationship in order to be trusted with offering some of these counter thoughts or balancing thoughts. Um, because it's not about putting your finger in their chest and telling them they're wrong. It's really about two people building a deep relationship and then trying to focus on how we can build more nuance and complexity in this experience in order to relieve some of the consistent and constant fear that's existing in the person's life. So, clarifying questions, matter of fact questions that are deeply sensitive but may hold key information to the maintenance of the stuck point. So, another example, I must have wanted this if it made me aroused. This is a common thought process that can occur during sexual assault. So, another one that really can highlight how somebody's welding two ideas together. So if I was mechanically or physically aroused during this experience, I was at the same time. I must have enjoyed it, as suggesting that these two things are completely linked. And so I think clarifying questions can help separate these out and break the weld of those two ideas that a person could be mechanically aroused, mechanically physically aroused without having wanted to participate in the act. Underlying assumptions. So again, sometimes underlying assumptions can act as maintenance for a stuck point. One common assumption is the just world belief. Again, we talked about that before, but it's the good things happen to good people, bad things happen to bad people. So what does this mean? This would mean we would have to be a bad person if we experience trauma or an adverse event. And so we would want to use Socratic dialogue to build more nuance into the assumptions and really try to break them down. Evaluating objective evidence. Sometimes current avoidance is maintained by subjective and unfounded fears in the here and now. Right. So another way to look at objective evidence. So earlier I talked about that temporal aspect. There's also the here and the now. So much of avoidance is maintained by now taking what you learned through a traumatic event and generalizing it to the world in an unhelpful way. All alleyways are dangerous, therefore I can never go through an alleyway, or I can never be in an urban environment again, perhaps. And so what we're trying to look at is undermining the credibility of the fear in order to re-engage in things that the person wants to engage in. So the goal would be to put people back in their lives as normally as possible. And some of those deeper beliefs. Schemas and deeper beliefs can hold these implications about changing thoughts. If a person doesn't want to give up a stuck point, it may be related to some cascading concerns. So, for a client whose father sexually abused them, for instance, shifting the stuck point to hold the father more accountable may result in a fear of losing progress made with her father since the abuse. So, this is an example coming out of the cognitive processing therapy manual, in which the person mm, benefits from um, the person benefits from avoiding accountability on their father, at least psychologically, internally. It's not dad's fault, and they benefit from that because the progress that was made in their relationship, any sort of repairing that happened, they're afraid that if they psychologically kind of start to process whether it was dad's fault, it may then disrupt the here and the now relationship. So there's this deeper belief that a person who's held account for these things, or even, um, if their behavior is explained in a different way, that it may damage the relationship as they have it now, and they want to keep that relationship. So I think this is a brilliant example they have in this manual because it really shows how these ideas can be welded together and where the dialectics, dialectics being the philosophy of two things at the same time that are seemingly opposite. Um, there's dialectics in really thinking through, okay, this person behaved poorly, committed some heinous acts, and I desire to be in a relationship with them still, does not mean that I then endorse or am saying that it's okay to do heinous acts. And I think that's a hard balance to strike for a lot of folks. And this is where some of that Socratic dialogue can help the person keep their autonomy, keep the people in their life that they want to keep in their life, while simultaneously encouraging them to let themselves off the hook if they are clearly and objectively not accountable for the traumatic event. Um, okay, so we talked a lot about cognitive processing therapy kind of techniques in general, but now we're going to talk a little bit about written accounts. So, cognitive processing therapy has two versions, one with written accounts of the traumatic event and one without. The author suggests that the client chooses at the beginning, and once they started, they stick with the version chosen. The written accounts are detailed, factual write-ups of the events, similar to a written exposure intervention. So if they choose to do the written accounts, it is literally detail of all of the events that would have occurred during the time of the traumatic experience. According to the authors, there's not a significant benefit to the written accounts in terms of outcomes, but a therapist should never discourage the written account. So this is important. A lot of folks do not have a space where they feel safe in sharing their their trauma narrative, and they don't have a space to tell their story so often in any um, personal life experience. So, one thing that therapy can be helpful for is creating that warm environment in which somebody can share their biography, even the most significant or hard details of their biography. So, similar to imaginal exposure, written exposure, or other exposure techniques, cognitive processing therapy has this written accounts. But to explain this more thoroughly or more concisely, maybe, is you do not have to have written accounts for cognitive processing therapy to work, and this is demonstrated by the evidence and by the data and by the randomized control trial. I am an exposure therapist. I appreciate exposure therapy and I try to work with it when I can. That being said, the authors have shown really compelling evidence that it's not necessary for recovery. So it's a really important thing to think through of when you offer it if they say no, I think they don't want to engage in the accounts. I think to you shouldn't lose optimism that they're going to recover from this experience. Now, at the same time, if they say yes, we need to hold them. We need to coach them through and hold their enthusiasm into engaging in it because it's really important that we don't start reinforcing avoidance inside of therapy. So really walking with them and reminding them that the choice was courageous and they should continue with it after they've made the commitment. So what do the session structures look like? I'll go through these pretty quick, but the procedures for session one, these are all directly out of the CPT manual, what the actual agendas are going to look like. I won't read them word for word, but I'm going to show some of the session structures on screen so you can see them. Often we're going to be setting an agenda and then we're going to review PCL5 and the PHQ-9, which is a depression screener. Um, Over all of the sessions, it'll often talk about screeners and reviewing these screeners before every session. A lot of this session is going to be about education and psychoeducation about what PTSD is, how it works, how it can be developed, sort of a little bit like we talked about here today, but maybe not as in depth. Session two, we're going to administer the PCL5, collect the form, review it. If they haven't done their impact statement, we're going to kind of work on encouraging some folks to like do it. You'll also be introducing some of the other worksheets and going through describing like stuck points more fully and sort of these things. I want to point out cognitive processing therapy is heavily homework based. Same thing with most PTSD treatments from the cognitive behavioral world because they tend to be very methodical in comparison to maybe more process based CBT or other cognitive behavioral interventions that are a little bit more cognitive therapy, Socratic questioning than they are agenda focused. But this particular treatment, this treatment is very agenda focused, very specific to a methodical protocol. Session three, again, kind of getting into the impact statement, um, working through the ABC sheets, which we would call those functional analysis and behaviorism. So ABC sheets are often another term you'll hear a lot is functional analysis. It's antecedent behavior and consequence. Antecedent being that Pavlovian trigger, the behavior of what it was the reaction, and then the consequence being that operant conditioning response that the environment or other people engaged in. And so ABC helps examine how our thoughts or our beliefs or however we're engaging in the world, it helps us examine these concepts and ideas more surgically. So it's a really strong benefit for a client to kind of break down their own thoughts and thinking practices in order to encourage them to work through some of the stuck points. Session four, kind of getting into more of the stuck points using Socratic dialogue. Um, and you start to see as we get deeper into these sessions, you start to see more themes of education show up. So the differences among the unforeseeable responsibility and blame is one of the handouts. In this one, we're introducing thinking patterns. That's often from the classic cognitive therapy, cognitive distortions concepts. So introduce those thinking patterns. Um, we're going to be talking about in this one, we're going to be doing the alternative thoughts. So this is the cognitive restructuring is another word for it that we'll use often as a technical term in cognitive therapy. Cognitive restructuring is really the alternative thoughts worksheet, but it's really cognitive restructuring is any sort of practice where you're attempting to change the person's view or perception of themselves, the world, or a particular event. It is the act of attempting to move the beliefs from where they are to where to more accurate is really what we're aiming for, to a more accurate interpretation. Procedures for session seven. Again, self-report measures right there on the screen. We keep doing self-report measures every time, keep collecting it. We'll be reviewing homework at the beginning of each session and then provide an overview of the specific themes. And the theme for this week tends to be safety, the first of of these themes. Next is we're going to introduce the trust theme. And then the next one is we'll complete a trust star worksheet, introduce power and control. And so a lot of building out and thinking through the education of how people think in these events. Next, we want to kind of get into the esteem theme. So we're talking a little bit about that. We're reviewing alternative thoughts, of course, and we're still working through the stuck points. Um, Session 11, discuss therapy termination, where we're getting closer to graduation, and then we introduce the intimacy theme. And of course, pause this anytime to look through the actual agenda. And then for 12, we're starting to get towards the original and new impact statements. We're reviewing the course of treatment. It's sort of a graduation session. So this is important as it has an encapsulation on it. So one thing I like to kind of share is if this was an interest, if this content is interesting to you, the kind of going through the cognitive processing therapy and the different structured sessions and how to show up and help somebody with PTSD, I would suggest going to the author's website, one of the for cognitive processing disorder. There's a website for the training of CPT. I would not suggest that you use this small workshop alone as a way to engage in cognitive processing therapy. Instead, using this workshop as a way to kind of deep dive into the theory to see if it's a good fit for you. And then if it is a good fit, I would encourage you to get some training. There was some fairly affordable training on here. They were distance workshops that you could do live via video remote, and so I would encourage that. Also, the second edition of the book is right there in the website, and I would suggest picking that up. And so here's a link to the training manual. I don't remember whether this goes to Amazon maybe or something to that effect, or maybe it's the publisher. I think it's Guilford, the publisher. So pick the book up. It's a great edition, the second edition, and it's got a lot of helpful content in it. This American Life is a podcast by NPR. It's really interesting. They did a reporter went in and did cognitive processing therapy where they went through 10 sessions themselves of cognitive processing therapy. This is their journey. So check out the podcast if you're interested in hearing what it's like from the client's perspective. Thank you. Any questions you have, feel free to put them in the comments down below.